Thank you very much, Dr. Surmelis. Thank you for the honor for me to present this. I'm going to share with you biomechanics in relation with elbow trauma. So basically, we've been through that. The elbow has three joints, the ulnar humeral, the radiocapitellar, and the proximal radial joint. The critical role of the elbow is well known in the ADLs. You can't reach and drink a cup of coffee if you don't have your elbow functioning. So those are the three joints. The ulnar humeral joint is basically a hinge type and is the primary stabilizer of the elbow. The coronoid tip is the anterior buttress, and that goes into the coronoid fossa of the anterior humerus. If we remove 50% of the articular surface of the olecranon, then we are actually fine with reattachment of the triceps. Radiocapitellar joint, like Dr. Zingeris was alluding to, is a pivot type joint. The functions of the radial head are well known. Basically, is a force transmission, 60% of compressive loads, and also synergy with the MCL into valgus resistance. So the primary stabilizer is the MCL, then is the radial head for valgus, as we shall see later. Cartilage, that was also alluded to earlier, only 2/3 are covered, and that has implications for ORIF. The range of motion, that has been alluded to by Dr. Zingeris as well. The important thing here is that the bone, it becomes less important when we start to flex the elbow, and that was shown by Dr. Vandridis. When you want to test the ligaments, then you got to have a little bit of flexion of the elbow rather than have the elbow in full extension, because you have the bony play in full extension. Carrying angle, cubitus varus versus cubitus valgus. We don't worry about the varus, we worry about the valgus, and if severe, it might need an ulnar nerve transposition. Again, that has been said earlier by Dr. Zingeris, 30% of anterior tilt of the joint surface, which matches the ulna, the 30 degrees of posterior opening, the valgus of the humerus, and the internal rotation as well. So the weight is distributed unevenly. So an applied force will go 60% through the radiohumeral joint and 40% through the ulnar humeral joint. As far as the static stabilizers, the coronoid is, like we said, the anterior buttress of the olecranon, prevents posterior dislocation, and fractures over 50% of the height of the coronoid will lead to instability. The MCL attaches at the base of the coronoid. Important in trauma is the anterior medial fragment, which is important to recognize, and it's hard to see on x-rays. So basically the problem here is you have an anterior medial fragment and an LCL tear, you will get the posterior medial instability, and if you don't see that, then can get early osteoarthritis as a consequence. The medial ulnar collateral ligament has three bundles. It originates from the medial epicondyle and inserts on the sublime tubercle. The anterior bundle, which is the most important, and it's important in valgus stress resistance. Remember, we said the radial head is the second most important. The posterior bundle, which forms the floor of the cubital tunnel, and the transverse bundle. The anterior bundle, in its turn, is divided into three parts: the anterior, the central, and the posterior. So the anterior, the central, and the posterior here. The medial ulnar collateral ligament, at 30 degrees of elbow, the laxity is maximal. Then, as soon as you flex the elbow more, it becomes more tensioned. There's an epidemic of the MCL injury, not in Greece, but in the United States, where baseball is very popular. So basically those two phases, so the late cocking and the deceleration phase, are the phases in which the MCL is the most vulnerable in. And basically what happens is the ligament gets tensioned, and like all ligaments in the body, it cannot withstand the force. But you have the muscles that we're going to talk about later, the dynamic stabilizers. So basically, those actually fire and at the same time prevent the tensioning force and the rupture of the ligament. So when you have an injury of the MCL, that means that the dynamic stabilizers have not fulfilled their role. So the ligament is subjected into too much force, and therefore it will rupture. Same deal with the ACL tears. Static stabilizers, so medial ulnar collateral again. Posterior bundle forms the floor of the cubital tunnel, it's tied in elbow flexion. And an interesting thing is that during elbow trauma, it can contract, and then to remedy this contraction, the elbow contraction, you release it. Transverse bundle, basically nobody knows what it's all about. We did publish a paper, and we showed that by releasing the posterior bundle and in some parts, in some patients, the posterior part of the anterior bundle, we improved elbow flexion. That was with Dave Rouge a long time ago. The lateral ligament complex, the lateral ulnar collateral ligament, the lateral radial collateral ligament, the accessory ligament, and the annular ligament. So the first one is the LUCL, which inserts the crista supinatoris, and it's basically the key ligament of the lateral complex to prevent varus and external stress. The lateral radial and the accessory lateral collateral ligament also contribute to the varus stability, but we don't know about how much. Then you got the annular ligament, and that's PRUJ stability. A key point is that you can basically destabilize the lateral side of the elbow when you do surgery. For example, when you want to do tennis elbow surgery, you've got to be careful not to basically release the ligament and cause iatrogenic instability. Other static stabilizers, radiocapitellar joint, we talked about that earlier. The capsule stability is basically comes into play when the elbow is extended. Then the dynamic stabilizers, and I'm just going to repeat myself here. So the ligaments only can withstand so much force, and then when you have the muscles at the same time, those basically provide the stability during dynamics of the elbow. So if for a split of a second the dynamic stabilizers don't work, then the ligament is vulnerable and it's going to rupture, and that's where the problem is. So you got the flexors and extensors, and you got the common flexor pronator tendons, origin, and the common extensor tendon of the lateral side. As far as motion, the center of rotation, as far as flexion and extension is concerned, is basically the center of the trochlea. And as far as pronosupination is concerned, there's an axis of rotation that forms a cone and basically passes through both of the radial and ulnar heads and the capitellum. So the clinical relevance of all that is basically, you know, that's useful to know, and sometimes it's difficult when you reconstruct the ligament to know what tension, what the role of the ligament is. I think biomechanics is helpful in helping us understand and better plan our surgeries. Thank you very much for your attention.